Okay, thanks for joining us, everyone, for this edition of Discussions in Diagnosis. It's my great pleasure to welcome Dr. Rose Gubitosi-Klug, our guest this morning. She is Division Chief of Pediatric Endocrinology and Metabolism here at University Hospitals Rainbow Babies and Children's Hospital. I remember her name. I used to be the medical director, clinical director of the Weight Management Center at Children's Hospital Pittsburgh a decade ago. And I think, Rose, you were involved in the Today study as well. And she's very passionate about prevention of type 2 diabetes. But that's not what we're going to talk about today. We're here to talk about type 1 diabetes and the changing landscape of diagnosis in particular. So welcome, Rose. Thanks for joining us this morning.
Good morning, everyone.
So I want to start with a situation that might set the stage for our discussion this morning. So let's say I have this situation. I'm seeing a 12-year-old girl brought by her mother because the child is complaining of fatigue and headache for the past 2 months. She's been previously well, has no significant past medical history. She's African-American. Aside from the fatigue and headache, she has no other significant complaints. She has good sleep hygiene. She has no mood disturbances, doing well in school. She's a very pleasant child. She doesn't appear fatigued during the examination. Her BMI percentile is 98.3, which means that she does have obesity. Her blood pressure is 130/84, which makes her hypertensive, according to the adolescent standard criteria that we have adopted over the last few years. Remainder of the physical exam is normal. I'm focused on this fatigue, and so is mom. And so I obtain a BMP and a TSH. TSH is normal. The BMP revealed a random glucose of 210 milligrams per deciliter. And as her primary care physician, I'm a little alarmed. So I ask her to return for a fasting reading, which she does a couple of days later. Her fasting value is 160 milligrams per deciliter, and the hemoglobin A1C obtained later is 8.8%. She has no history of hemoglobinopathy, and she doesn't have any family history of diabetes. So I think the question for you is, where would I go from here? And I think it's one that a lot of our folks in primary care would love to learn more about.
Yeah, this is a really great question. And this is a really great case because it really shows you that changing face of type 1 diabetes, where we have now a rising incidence of type 2 diabetes as well. So is she type 1? Is she type 2? You've hit on many items here that, she is overweight, which may make us think about type 2. She has some hypertension, whether that's being in the clinic or, certainly hypertension at presentation would go along with type 2, but she doesn't have any other clear symptoms. Her physical exam is normal, so we don't see acanthosis nigricans, which would be another sign for insulin resistance, and she doesn't have a family history of type 2 diabetes, which again would factor in. Clinically, you have that random glucose above 210, but you don't have symptoms. You haven't described the classic polyuria, polydipsia, polyphagia, maybe some weight loss. And so you pick this up really early in that you don't have those symptoms. You bring her back and she's got the fasting now. So the fasting blood glucose greater than 126. The random glucose, over 200, also part of the diagnosis, typically with symptoms. Otherwise, but it is actually a serum glucose. So there you have that. So you really have made diagnosis here. But then that A1C, which is now in the last few years been part of our diagnostic criteria, anything over 6.5%, greater than or equal to, is diagnostic, and that's an A1C done, not a point of care one, which we have in our endocrine offices, a point of care A1C, but really the gold standard one done in most laboratories nationally now. So you've made this diagnosis. So again, where do we go? I'll comment, no hemoglobinopathy. Sometimes, certainly anemias, other hemoglobinopathies, anything that shortens that red blood cell life can alter your A1C reading. This is still not a borderline A1C, 8.8, definitely high enough. So this child really needs to be referred to endocrinology and started on insulin, actually, even though we're still maybe considering is this type 1 or type 2. it really needs insulin once you have an A1C above, 8.5%. That's our kind of criteria in the type 2 world. But in type 1, insulin deficiency is insulin from initiation. So the other key point here is, we really don't know on a time scale. We can't predict who will go into DKA. So always have to think type 1, still 90% of new onset diabetes in children and adolescents is type 1, although type 2 is raising, and a recent article out last month suggests that over time, type 1 is increasing at a rate of 3 to 5% annually, whereas type 2 is increasing at 8 to 12% or more. So over time, if the type 2 incidence continues to rise and we can't prevent type 2, then by 2060 we're going to see almost a 50-50 split of type 1 and type 2 in pediatric cases. So you've really honed in here that this is probably type 1 given the scenario. So we need to start some insulin. So she would get referred to endocrinology, and we would start the standard of care, multiple daily injections. We would probably initially, since she isn't overtly polyuric polydipsic, and we would initially check and make sure, it sounds like the BMP, the bicarb was unremarkable, so we don't have DK. We'd repeat it because she could have slipped into DK between the 2 or 3 days. And then we would see her glucose trends and determine her basal needs and her mealtime bolus needs. And then we would follow her very carefully, train the family to do glucose monitoring, which is still the hallmark of initial management and titration of insulin over time. So I think that's the big thing, is we don't know when DK presents. So you get that random, you got to follow up quickly with it and try to make this diagnosis, so that, because we know even, it used to be when I started residency fellowship, you always reassure parents, this is the initial presentation, you have DKA, if we take insulin, this will never happen again. It doesn't have any long-term sequelae. But more recent studies following kids after even the first DKA, there's cognitive deficits that they've identified over time. So the real push in the type 1 field is avoid DKA, find these kids, capture them, and get them in before DKA.
Thank you, Rose. So I think that philosophically, that certainly makes sense. Let's avoid DK. Let's get her on insulin. And perhaps let's worry about distinguishing between type 1 and type 2 a little bit later, which is, conventional wisdom here. But would you talk to us a little bit about testing for hemoglobinopathy, which we have no history of, and distinguishing between type 1 and type 2? Let's say we've got her on insulin. Maybe it's Texas Children's has a protocol. I think it's a once nightly long-acting insulin as a starting point, and there's a weight-based algorithm for it. But let's say she's under reasonable control, and she comes back to you. How would you distinguish between the two types of diabetes?
Yeah, so when she her initial new onset labs, as we call them, include all of the autoantibodies. The NIH study TrialNet has really taught us a lot about autoantibody progression, and there's now a staging classification to type 1 diabetes, where you have the first autoantibody, and then you have 2 or more autoantibodies and some dysglycemia. And then over time, stage 3 is when you actually present with overt symptoms. So trying to, again, catch these kids in stage 1, the early autoimmunity, stage 2, where they just have autoimmunity with dysglycemia before they actually go on to stage 3. And again, when they might be at highest risk for DKA. So we always draw the autoantibodies. There's even prediction models. Many families where there's one child with type 1, they often say, what about my other children? They can enroll in TrialNet, or if they ask us, we'll do the autoantibodies. We still don't wide scale screen siblings with autoantibodies, but that's gonna be the next diagnostic. So if they come back with even one autoantibody positive, that's type 1 diabetes. Sometimes they come back and they're all autoantibody negative. Again, then we look for the other features of type 2 diabetes. We might consider, if there's any consideration, we might start some metformin at that point. But typically, even autoantibody negative, that their insulin requirements are high, they're going to remain on insulin. But autoantibody positive is still our classic definition for type 1 diabetes. Now we know from today's study that you mentioned that even kids who are overweight and look maybe like type 2, they may have autoantibodies. And so the thought is that their obesity, their excessive waste caused some insulin resistance. But with the autoantibodies, they were destined to be a patient with type 1 diabetes. So again, prevent that DKA, prevent any adverse events, and keep them on insulin.
Thank you. Is there any role for additional testing, fasting insulin, for example, C-reactive protein in these kids?
Yeah, I mean, when they come in, they'll get that fasting insulin level, which, if it's sky high, that makes you think, okay, this is not type 1. But even, there's glucose toxicity. It can make you have a falsely lower one in a patient with type 2. So we definitely do look at it. I think, that comes back very rapidly. Parents are wanting reassurance. They're wanting to understand what's going on. And so if you do have a comeback and it's very low, again, it reassures parents, okay, insulin is needed right now. And it helps them with their coping and their acceptance of what's coming ahead. Yeah.
Great, thank you. So you mentioned that the incidence of type 1 diabetes is going up. Type 2 diabetes is, of course, increasing in incidence, which we would expect with rising levels of obesity. But can you talk to us a little bit about risk factors for type 1 diabetes?
Yeah, so there's been a lot of work going on risk factors. We don't really understand the environmental factors really well that's pushing type 1 diabetes, but there's definitely genetic factors as well. So we all remember HLA, DRDQ are high risk. There's genotypes, but there's haplotypes. Some are high risk for type 1, some are lower risk or actually beneficial in protecting from type 1. But even those with high risk, only about 10% of those with high risk HLAs go on to develop type 1 diabetes. So there are other genetic risk factors. And more recently, they did genome-wide association studies and have come up with genetic risk scores. We don't use these clinically yet, but I anticipate these panels will probably be coming out where you can do a genetic risk score based on 30 other genes that have been associated with modulation of beta cell autoimmunity. And so there's a genetic risk score for type 1, there's a genetic risk score for type 2. It can help you, again, determine type 1 versus type 2. It can also help you in cases of when you think about MODY. That's something also to consider, a monogenic form of diabetes in youth, which again, like no family history of diabetes here, really made that much less likely. That's when you find really an autosomal dominant pattern of diabetes in a family, and that would heighten your risk for MODY. As well as we follow patients if they're autoantibody negative and they go through what we think is the honeymoon, but in essence they have this prolonged honeymoon. Normally it's maybe 6 months, and by a year they're back up to a unit per kilo per day of insulin. If they remain in a very low insulin dose, that's also when we think about MODY. So it's again one of those things you think about over time, but immediately treat with insulin.
Thank you, Rose. So I'm curious because I know in some settings, and this is not everywhere, and it may not be in Cleveland, for example, and you mentioned this, we are headed to a situation where type 2 diabetes might be 50% of all cases, and it's certainly not now. But it is a significant proportion in Texas and out west in particular. I'm just wondering, because there are screening criteria for type 2 diabetes. You look at, blood pressure, family history, acanthosis nigricans, et cetera, et cetera. Given this really complex picture, should we get autoantibodies when we get, just as soon as we measure hemoglobin A1C and fasting glucose?
I think that can be very helpful. There's a panel 4 that we use. You have 65 autoantibody, insulin autoantibodies, the IA2, which is an insulinoma, and then the zinc transporter, zinc T8, which is kind of the newest one that was added to the panel. It was more in a research mode, but now we measure it more often clinically. And some will be negative for the first 3 and only have zinc transporter positivity. And again, it's helping that family really accept the diagnosis and and move forward with just treatment and life and making and keeping diabetes part of their lifestyle and controlling the diabetes and not having the diabetes kind of override their lives.
Thank you. So can you comment a little bit about beta hydroxybutyrate testing as well?
Yeah, I mean, that's one of the largest ketones generated during DKA. There are home test meters now for ketone testing, and we have them in our clinics as well. So it has a role again in DKA of really how are we managing our ketoacidosis, because what has also developed over time here with the pandemic and I think delayed presentation sometimes, families staying at home and with symptoms, and then later presentations is kids come in not just with DKA, but a mixed picture with a very hyperosmolar state as well. And so in the ICU, when we're managing them, it's a balance here, because hyperosmolar state, you really need more fluids than traditionally in DKA, but you have to monitor how your ketoacidosis is going as well. So it has a role in the ICU, but it has a role at home too once they're diagnosed with diabetes, especially in the young patients, the toddlers. The highest incidence of type 1 is in the under 6-year-old range right now. And you can't always tell how their symptoms and pick them up. And so the home test kits allow us to help families to stay at home more, to catch early ketosis, give a little extra insulin at home, and prevent hospitalization. So it's a nice test. In a doctor's office, if you do a finger stick glucose and it's high and you've got ketones, that means, send them to the ED, because again, we want to avoid DKA. So I think that may become more commonplace over time as well. I don't know how many of your practices have it now.
Yeah. Thank you. So I'm thinking that this is, we talked about this case study. It's going to be pretty traumatic for the family. They come in, a young girl feels well, has got some headaches, got some fatigue, and winds up with a diagnosis of type 1 diabetes within a couple of weeks. That's got to be quite a bit. Can you comment a little bit about prognosis? Because I read an editorial recently that said, some degree of baseline hyperglycemia is inevitable, and that complications are very difficult to prevent. And it's so hard to get the balance between glucose control and hypoglycemia. So how do these kids do in the long run?
Yeah, no, it's a great question. There's a really bright future for type 1 diabetes. And I have to say, in the last 4 or 5 years, with just so much innovation and technology that's available to help with home monitoring of glucose and insulin, and what we call an automated insulin delivery device, where you have a pump that's delivering continuous infusion of insulin, and you have a continuous glucose monitor device that's every 5 to 15 minutes telling you your glucose, alarming you if you're rapidly rising or rapidly dropping. And then the two working together, where the glucose monitor is sending the glucose value to the pump. The pump is then going up or down on the insulin infusion to bring that glucose back into the target range. And this works autonomously, without the individual having to do anything. So baseline glucose nocturnal hypoglycemia is almost non-existent with these devices, because it works in the background. And the only thing it can't do, independent of the individual, is give a bolus for a meal. The algorithms are not quick enough to ramp up the insulin for a meal, but that's coming. So at some point it will be. So I think that and I also wanted to mention, it is a traumatic diagnosis, because with type 1, we don't have a cure right now. But what we're working on is, and the hospitalization is traumatic, can be as well. But in a case like this, where there's no symptoms, they're overall stable, we're working on having, and we should have it up and running in the next year, a new onset outpatient clinic, so they don't actually have to be hospitalized, but they'll have a 2-day outpatient, where the first day they get started insulin, they come back the second day and complete their education. Again, kind of to emphasizing that this is a disease that you can manage. Here are the tools. I have to say, everybody learns finger stick, but we have kids within a couple weeks after going home that they're on these continuous glucose monitors, and these can send your glucose levels to phones shared via app with parents so that everyone can kind of watch these trends. It's that knowledge is power reassuring. They can be on iPads next to the bed, when they're very young, almost like a baby monitor that parents are, I think, sleeping more. The alarms are there and set in place to help families. So I think it's a really bright future with regards to diabetes management. And I know just from reviewing our recent data that these new automated systems have taken kids who've had A1Cs of 8 and 9% down into the 7.5% within 3 months. They don't come without burden of their devices, so you have to troubleshoot. But I think it's a really different future for kids. And one last thing I'll mention is we did do a review recently in one of our long-term studies of type 1 patients for 40 years, looking at each decade. We know that getting your A1C under 7% from the start reduces your risk for complications significantly, and that's the goal. But what if you struggle for a while and then you're able to get under 7% later in life? So we looked at different decades, and the result is, it's positive. At any point, if you can get into and maintain target range, it will have a long-lasting benefit. So even if it's just hopeful message, that even if there are families for a variety of reasons that struggle in the beginning, if they can, after 5 or 10 years, get their A1C down that 7% and maintain it, they will get some benefit from the reduction of long-term complications.
Great. It sounds like technology is what's really playing a role here in improvements. Wonderful. Thank you, Rose. So we have some questions. I'm going to actually read through a couple of our questions in the chat, then we'll throw it open to everyone. So I think Dr. Saeed is asking, what's the role of testing for C-peptide? Would that be something you'd routinely test for as well?
Yeah, we do at diagnosis as well. So it's insulin, but you're right, looking at endogenous generation and C-peptide, which lasts longer. Insulin's more short-lived in the bloodstream, so we definitely check for C-peptide as well.
Okay. And Dr. Chuck Macias has a question about hospitals who are they building prediction models into their EHRs? Of course, there's a lot of excitement in our institution now around the EHR. The way cognitive computing models are built for asthma. Any developments there that you're aware of?
That's a great question. And so there's a lot of EHR platforms that are being built for diabetes. I'm not actually sure. That's a good question about prediction models, because we do have these prediction models with the autoantibodies, and so it's something that could be, once you're 2+ autoantibodies, you're going to present with type 1 typically within 5 years. So it's something that that could definitely be done.
Yeah, I think the prediction model would be helpful from the primary care standpoint. I'm just wondering if even a clinical decision support tool, once I have that elevated glucose level and it's a kid, what do I do now? Would be helpful as well. You get the hemoglobin A1C. Should I get antibodies? Should I get a C-peptide? And almost, hey, this is most likely type 1 or this is most likely type 2. That might be helpful as well. Okay.
Yeah, the autoantibodies can take 3 or 4 weeks to come back.
Yes.
So, that's the only thing. So, we send the kids home, and then they come back at 1 month for a 1-month visit, and that's when we can share. Some families are eager, though. They call earlier. What's my autoantibody status?
Great.
That's the only thing. Yeah.
Dr. Hollick has a question. Raj, go ahead when you're ready.
Good morning. I wanted to talk to you or get a little bit of your feedback, Dr. Rose, on the new drug, teplizumab.
Yeah, thank you for bringing it up. Yeah. So teplizumab was just FDA approved, and that's why the staging of type 1 prediction models, catching these kids earlier. So teplizumab interferes with the autoimmune process, and so has been demonstrated to prolong C-peptide, prolong the pancreatic beta cell function, and so delay the onset of type 1 diabetes. So it was studied in stage 2, where there's some dysglycemia and some autoantibody, and so it has delayed it for more than a year, which is huge for many reasons. First, it's the first drug that's been FDA approved. It's a 14-day infusion, and we're actually working on a protocol and hope to be up and running with this within the next 6 months for sure. And we will, so you give this Tzield and it delays the onset. That's important, one, because type 1 diabetes is a burden. Two, because there's many other drugs that are in the pipeline that act differently. And so it's always been thought that it probably won't be one medication that prevents type 1. It'll probably be a combination cocktail. So this is the first one. So you delay it to the point where there's a second, drug approved for somebody. And the other reason it's really important is that we also know from long-term studies that if you can preserve just a little bit of beta cell function, and endogenous secretion, it benefits you with your complication risk. And we even know 30, 40 years, if you it used to be that beta cell function curve went to 0. We thought there's no cell function, there's complete insulin deficiency. We now know, and likely because we are more effective with our initial therapies, that you can preserve beta cell function for 30, 40 years. And even if you have a low level of C-peptide of endogenous secretion, you can drastically reduce complications. And then the biggest thing after 30, 40 years is reduce severe hypoglycemia. And people with residual beta cell function, they were the patients who never had a severe hypo, which is huge because we know chronic hypo or hyperglycemia over time can lead to actual structural changes in the brain. We published that in the last year as well. And so you really, that's the target, is preserving a little bit of beta cell function. So the earlier you recognize, the earlier we treat, the more we can prolong the onset and preserve beta cell function. Again, it will be better outcomes down the line.
Thank you, Rose. I think we'll take one more question if there is one. If not, we'll have to wrap up. Okay, well, thank you so much. A wonderful, fascinating discussion, Dr. Gubitosi-Klug from Pediatric Endocrinology here at University Hospitals at Rainbow Babies and Children's Hospital. Thanks everyone for joining. Next week, oh, I'm sorry, we do have oh no, Sarah was just clapping. Thank you. Next week, we will be talking about coronary artery calcium scoring and its role in diagnosis of heart disease. And my guest next week will be Dr. Ian Nealand. So thanks everyone. Have a wonderful day. And thanks again to Rose. Take care. Bye-bye.
Thanks everyone. Bye-bye.